All right, friends, good morning or afternoon, as the case may be. We are so excited so many of you are able to join us for our national webinar today. Before we get started, just a couple of reminders. Everyone will be muted throughout this presentation. But please do send your questions to the presenter during this presentation. You can type them in either in the chat feature or in the question part of the toolbar. You'll be able to see it. We will be doing a Q&A at the very end of the presentation, so we'll try to get through as many questions as you have. This is a reminder that this presentation is being recorded and will be posted on our website in our resource library, and you will get a follow-up email with a link of where you can find this. Also want to let you know that you will be receiving an evaluation at the end of this presentation with a couple reporting questions. So please take some time to fill that out, and we're going to go ahead and get started. We're so excited about our topic today. It's Understanding ACEs, and we have a fantastic guest speaker, Jane Stevens, who will be jumping in just a minute here to present on such a wonderful topic. And we had a lot of interest. I think we have about 900 folks registered for this webinar. So again, we're really honored and excited that Jane could join us for such an important topic. Before we get started, just wanted to introduce myself. I will be your host and helping facilitate this webinar today. My name is Natalia Aguirre. I'm the National Director of Family Justice Center Alliance. And we also have a lot of our staff members supporting in the background. So thank you, Riley and Bryn, for helping us with the technology today as we handle a very large webinar. And again, just another reminder for those of you as you join, this webinar is being recorded and you will receive instructions on how you can download and view the recording once it has been posted. It will take us just a couple of days, so bear with us and you'll get all of the materials as well as the handouts that correspond to this presentation. And as always, we like to give a big thank you to the Office on Violence Against Women, Acting Director Laura Roger, and our very special program manager, Kevin Sweeney, who for making this training possible and for supporting us and also providing leadership and their vision. And I also want to give a big thank you to our team. As you know, these things don't happen seamlessly, and it takes a lot of people doing a lot of coordination and behind the scene work. And so again, just a big shout out to Bryn and Riley, who are part of our Family Justice Center Alliance team. And Casey and Gail both wish that they could be here with you. Casey is at 3 weeks of Camp Hope and very happy spending his time with kids in our program. And then Gail just got back from a trip from UCSB and is feeling under the weather, so we're sending her our love and hoping that she's feeling better today. But a big hello and thank you from all of our team for joining us monthly on these very important webinars. And then also we want to see you. If you are a Family Justice Center community or looking to start a Family Justice Center, please join us at our 10th Annual Leadership Summit. It's September 24 to 26 in Oklahoma City. And we are taking registrations now. Registration is now open. So if you will be receiving an announcement on how you can register very shortly. So we hope we see you in Oklahoma City soon. And with that, I'm going to go ahead and introduce our guest speaker, Jane Stevens. Again, Jane is the founder and publisher of ACEs Connection, comprising of the social networks acesconnection.com and the news site aces2high.com. The site focuses on adverse childhood experiences science and how people are implementing trauma-informed and resilience-building practices based on that science. The network is supported by funding from the Robert Wood Johnson Foundation, the California Endowment, and the George Sarlo Foundation, among a few others. And Stephen has been a health science and technology journalist for more than 35 years. Her articles have appeared in the Boston Globe, the New York Times, the Washington Post, and the Los Angeles Times, as well as the National Geographic. She began reporting about the CDC Kaiser Permanente ACE study and the other 4 parts of the ACEs science since 2005. And she's lived and worked in Kenya and Indonesia and has been to Antarctica in the winter 3 times on reporting fellowships. Again, Jane, we're so honored and privileged to have you here. Thank you so much for doing this for us, and we're really looking forward to this presentation, so take it away.
Thank you, Natalia. This is wonderful. I am so glad to be here, and I'm thrilled that there's so much interest in all of this new way of looking at human behavior and how we can change things. So I'll start by talking a little bit about the ACE study. But before I do that, I just wanted to tell you what ACEs Connection is, basically. It's a social network that supports communities to accelerate the use of ACEs and resilient science to solve our most intractable problems. And there's just a couple of examples I want to give you before we start. And these examples are what get me up in the morning, because it's just amazing what is happening when people integrate this new knowledge about ACEs science. There's an elementary school in San Diego that has stopped suspending and expelling students. They don't need to. The kids' grades and test scores and attendance climb. The teachers are happier and less stressed. There's a health clinic in Pueblo, Colorado that has seen a 30% drop in visits to the emergency room after they integrated ACEs science. And after 1 year, family courts that integrate Safe Babies Courts approach saw a 99% of the kids suffering no further abuse, and that has continued since they started integrating ACEs science into their work. So I'll move on here. By the way, if you want to become a member of ACEs Connection, and I hope you do, because there's lots of information on there for you in your profession as well as for you in your community. And there are actually thousands of people now who are using ACEs Connection, which is another thing that gets me up in the morning. So let's start the overview on the Adverse Child Experiences Study and ACEs science. So ACEs science has 5 parts, and the first part is the epidemiology, which is the ACE study, and there are probably, I don't know, hundreds of ACE surveys and studies that have been done now, and the information has been replicated countless times to show in the ACE science how valuable this is. There's the impact of the brain of toxic stress from ACEs, especially children's developing brains, because toxic stress has been shown to hurt their structure and damage the function of their brains. The impact on the body, the health consequences of toxic stress from ACEs, epigenetics, which is just how toxic stress is passed on from generation to generation, and that's often called historical trauma. And then there's the good news, which is resilience, that the body can heal. The brain is plastic, and there's plenty of people who are integrating resilience practices to show how not only can we heal individually, but we can heal in our organizations and in our communities. So let's start with the ACE study. The ACE study was first published in 1998. There have been 70 publications since. And it started with these 2 guys, Robert Anda and Vincent Felitti. Rob Anda was at the CDC at the time, and Vincent Felitti was at Kaiser Permanente. They recruited 17,000 people, and these are all members of not ACEs Connection. They're all members of Kaiser Permanente, and so they reflected the population of Kaiser Permanente at that time, which was mostly white, college educated. They all had great health care because they're members of Kaiser, and they all had jobs because you have to have at that time, you had to have a job to be a member of Kaiser. So they looked at 10 different types of childhood trauma. And they knew from the beginning that childhood trauma isn't limited to these 10, it just happens to be these 10 that they studied. So as you can see, we're probably familiar with the 5 usual suspects: abuse and neglect, and there are also 5 household dysfunctions. that depending on the population you're serving, many people consider normal because they're so common. Subsequent ACE surveys include other types of childhood adversity such as racism, sexism, bullying, witnessing violence outside the home, and living in unsafe neighborhoods. The ACE study actually had 5 major results. 1, childhood trauma is extraordinarily common. Nearly 2/3 of the 17,000 mostly white college-educated people with jobs and great health care experienced at least one type of serious and chronic childhood adversity. 12% had 4 or more. Secondly, there's an unmistakable link between adverse experiences in childhood and adult onset of chronic disease, mental illness, violence, and being a victim of violence. The third finding is that with more ACEs and without resilience factors, the more dire the consequences. Things start getting serious around an ACE score of 4. Compared with people who have 0 ACEs, those with 4 types were twice as likely to be smokers, 12 times more likely to have attempted suicide, and 7 times more likely to be alcoholic. And also it doubles the risk of cancer and triples the risk of lung disease. People with high ACE scores are more likely to be violent, have more marriages, more broken bones, more drug prescriptions, more depression, more autoimmune diseases, and more work absences. Without intervention, those with 6 or more ACEs have a lifespan that's 20 years shorter than those with 0 ACEs. Here are the impact of more information about the impact of people who have of ACEs and people who have 4 or more. It's pretty astounding, the consequences of having a lot of childhood trauma. And here are some more information about what happens with people with ACEs. And here's an interesting, some results. So I did an anonymous ACE survey at a presentation I was making in Sonoma County a while ago. And here are the comparisons. Now, the people who came to this Blue Ribbon event were people who were in the healthcare community and social services. So you can see that people tend to go to working in these professions probably because of things that have happened to themselves when they were kids too. So here is another interesting way at looking at what happens to people with ACEs, which is the risk factors in all these different areas, in disability and domestic violence, IV drug use, but also hopelessness. That if you have all these things happen to you when you're a child, you're generally not going to be having much hope for the future because of all the problems that you're dealing with as a child and then as an adult. So what's interesting about all this is that the 4th finding of the ACE study was that ACEs contribute to most of our chronic health, mental health, economic health, and social health issues. And the 5th finding is that it didn't matter what the types of ACEs were. An ACE score of 4 that includes divorce, physical abuse, an incarcerated family member, and a depressed family member has the same statistical health consequences as an ACE score of 4 that includes living with an alcoholic, verbal abuse, emotional neglect, and physical neglect. And what this means is that the body can't distinguish, the brain can't distinguish between the types of trauma. It just sees trauma. So since the ACE study was first published, it's expanded the number of ACEs, as I mentioned earlier. And so here are some other parts that weren't added in the first ACE study that are now added. Here's a pair of ACEs that Wendy Ellis put together, which says it's not just what happens in the home, it's also what happens in the community and in our systems. So you get structural racism, substandard wages, community violence, community disruption, lack of jobs, poor housing, all of that contributes also to ACEs in a child. And then the third piece of this, which we're beginning to grapple with, is climate change and natural disasters. This also has an effect on children and families. So let's look at the impacts of toxic stress caused by ACEs. So toxic stress is the biological response to severe and or repeated adversity, absent buffering support from a caring and trusted adult. And that relates to what I mentioned earlier, which is the brain cannot distinguish between types of childhood adversity. It just translates all that to my brain is hurting and I'm suffering the results of that. So babies aren't born with fully developed nervous systems. So exposure to toxic stress causes prolonged activation of stress response mechanisms. And this condition disrupts the development of the brain and other organs. In fact, every organ can be affected by this. And the long-term result is that there's an increase in the risk of stress-related disease and cognitive impairment. And all this comes from the American Academy of Pediatrics. There's also hyperarousal in response to stress, which leads to an excessive release of the hormone cortisol, weakened neural connections, the connections between our nerves, resulting in increased levels of fear and anxiety in response to stress, and changes in genes via their chemical markers predisposing to chronic inflammation along with a suppressed immune response. So all these things are happening in the brain and the body. And the consequences of staying in red alert puts a lot of wear and tear on the body. So even if people haven't smoked or aren't obese, their risk of heart disease and diabetes increases, as do autoimmune diseases. This is the third part of ACEs science, what happens to our bodies when we're living with toxic stress for years. And there are two terrific books about this. One is by Donna Jackson Nakazawa. It's called Childhood Disrupted, How Your Biography Becomes Your Biology and How You Can Heal. And the other by Bessel van der Kolk, The Body Keeps the Score, Brain, Mind, and Body in the Healing of Trauma. I highly recommend them if you haven't read them. The fourth part of ACEs science is epigenetics. So toxic stress can turn genes on and off. I mean, I think that a lot of people know that we're born with a complement of genes, but they're not all turned on and off. And the things that happen in our environment, our social environment, our family, our community, can change our genes. And these genes can be transferred from parent to child. The area of research that looks into this is called epigenetics. It's also referred to as historical trauma or generational trauma. Because toxic stress damages DNA and some populations are predisposed to certain genetic disorders, ACEs can contribute to and intensify poor health outcomes across multiple generations. All right, that's all the bad news. The good news is that our brain is plastic and our bodies want to heal. And that healing takes place in a number of different ways. One of the ways is just understanding all this ACEs science. And the four main parts to understand that open the door for people is that we weren't born bad. We weren't responsible for the things that happened to us when we were children. We coped appropriately, given that we weren't offered any other ways. It kept people alive, and that goes for things like drinking too much alcohol or smoking or eating too much, because we were coping with the remarkable, horrible stresses that we were having to deal with. And if we weren't doing that, then we're going to give up, and that's suicide. And the fourth piece of this is that we can change. And that is, a lot of people have already shown that, both on their own individual changes as well as in organizational and hopefully soon systems change. So what we can do for ourselves is integrate all of this into our lives: safe and supportive relationships, exercise, enough sleep, living in healthy places, mindfulness. Dan Siegel called that flossing for the brain, and then support in our mental health, whether it's from friends or from professionals. Now, there's two different kinds of trauma-informed approaches. One is for ourselves and the people we interact with individually. So the interpersonal part of this is, instead of asking what's wrong with you, is saying what happened to you and how can we help? And the other part is organizations and systems, because instead of saying what is wrong with this organization, the system, what has happened to this organization or system, and how can we help heal it? Because we don't want to do blame, shame, and punishment anywhere with this. So we're going to put trauma-informed principles into practice. And one way of addressing that is saying, well, what does a trauma-informed organization look like? And what it looks like is Lincoln High School. If any of you have seen Paper Tigers, that shows that the remarkable progress that Lincoln High made for its students, and how it turned around that school to be a safer place for kids where they developed hope. So not only schools, but health clinics, juvenile detention facilities, businesses, the faith-based community, recreation. There are organizations in every single sector that have or are integrating trauma-informed practices based on ACEs science. In other words, you've got to walk the talk. So I invite you to look at your own organization through a trauma-informed lens. If you do, that will lead your organization to looking at the people you serve as your partners in developing solutions, with the understanding that ACEs touch all of us. We all swim in the same ACEs ocean. We all breathe the same ACEs air. If we don't have ACEs, we're affected by, we know people that have ACEs, and we're affected by the consequences of ACEs in our organizations and communities. So some basic examples of a trauma-informed organization include an organization that doesn't have gossip. There's no assuming. Instead, people ask questions. People don't take other people's actions personally. There's transparency in policies, shared decision-making, and integrating self-care. And these are based on the SAMHSA's 6 principles of a trauma-informed approach, and that's safety, trustworthiness, empowerment, collaboration, peer support, history, gender, and culture are integrated in this too. So how that spools out into organizations is by these 4, whoops, I went too fast, sorry, is by these 4 parts. That the organization realizes that the widespread impact of trauma and also understands the potential paths for healing, recognizes the signs and symptoms of trauma in staff, responds by fully integrating knowledge about trauma into policies, procedures, and practice and settings, and fourth, avoids re-traumatization. And this shows up in hiring and HR practices, in professional development, in staff self-care, and attending to team development, psychological safety. And there really isn't one part of what happens in an organization that is unaffected by ACEs, and also that can be helped by integrating these trauma-informed practices. So I want to give you an overview of ACEs Connection, but not the California Community Resources. Sorry, I didn't mean to include that slide, but the overview of ACEs Connection is important because it will explain not only what's happening in the ACEs community, but also a little bit about how we've responded to what people in the community need, so that we provide the tools and guidelines that people in the community have asked for, and that you can take advantage of if you aren't part of that community yet. So ACEs Connection, as I mentioned earlier, is out there to solve our most intractable problems. It's a social network. Some people call it the Facebook for the ACEs movement, but with a whole bunch more bells and whistles. I launched this in 2012 because I saw a need to educate the public about ACEs science and to create a social network for people interested in this new and emerging field. Over the last 7 years, membership in ACEs Connection has grown to nearly 35,000 people from more than 40 countries, and more than 300 city, county, regional, and states with ACEs initiatives have community sites in some stage of development on ACEs Connection, and the number continues to grow. And these are people who are doing something in the ACEs movement. And that's why we want people to join, not just to watch, but to get engaged in their own work, in their own community, for themselves, for their organizations, and for the systems. And here's my wonderful ACEs Connection team. I couldn't do any of this without them. They are fabulous and talented and wonderful. So we have 2 sites, ACEs Too High and ACEs Connection. ACEs Too High is a site for the general public, and in ACEs Connection, because that's a social network, it's a place to dive deep and has a lot of resources and guidelines and tools that people can use who are doing something in the ACEs movement. We have a calendar section, we have videos, we have maps, we have all kinds of things, and members can message each other through the network. It's actually quite an active community. There are probably 2 to 5 million page views or activities on the network every month. We have a resources center with lots of resources, and we keep adding to that. And we tell stories on ACEs Connection. And this is an example of one, Lincoln High School, that I mentioned earlier. And there are other examples. For example, a family physician in Tennessee who integrated ACEs science into his work with opioid patients. And now 100% of his patients have jobs, which is an indicator of recovery. And he looks at the being addicted to opioids or anything as a chronic health issue like diabetes, that you always have to tend to it. And I hardly agree with him on that. Because it's a social network, people in the community can post information. So this is a post by Becky Haas, who is former director of the Johnson City Police Department's Community Crime Prevention Program. And now she's trauma-informed administrator at Ballad Health, one of the leaders in the Northeast Tennessee ACEs Action community. And so all of the, just like Becky has done here, members can post videos, calendar events, and comments and message each other. And that's how the ACEs movement grows, because I can't tell you how many people contacted Becky after this article that she wrote, wanting to know how they were so successful in changing their school when they integrated ACEs practices, and she provided this how-to for them. Plus, you know, lots of connections afterwards with more information that people wanted. The other part of ACEs Connection is how we support communities and the work they are doing to integrate trauma-informed and resilience-building practices based on ACEs. We have interest-based communities and geographic communities, and they're all mini ACEs connections. So it's kind of like Russian nesting dolls. We have lots of communities on ACEs Connection that look like and operate like ACEs Connection does, and but it's a community's own site, its own place within ACEs Connection. So you can find it by going to the community section on the homepage. And by the way, you can also find all the communities on the Mapping the Movement section, which is right next to the Communities tab up there. And that has a map of all the ACEs communities that you can click on and get more information about. So here are some of the interest-based communities that we have on ACEs Connection. There's ACEs in Pediatrics, Parenting with ACEs, which by the way was first called Domestic Violence in ACEs. And I realized that we didn't want to continue to make talk about domestic violence in the way that we have been. We wanted to talk about what it is, which is essentially parenting with ACEs, and how you can be a better parent when you understand your own ACEs, and you have a better shot at then changing how some of the things that have been passed on to you that you don't want to pass on to your kids. Here's an example of a state initiative, and there is Nadine Burke-Harris, who is the state's first Surgeon General, and she's completely focused on integrating ACEs into the state government, as well as encouraging people to integrate it into their organizations and their lives and their systems. Here's an example of a community site, and that's in Sacramento. And here are some of the tools that we provide. What communities, generally speaking, what they first start doing is doing a lot of ACEs presentations in their community, and so to help them keep track of that, we developed this tool where when they do a presentation, they fill out a quick 5-question Google form, and one of the questions is, what sector did you make this presentation to? And so it's color coded so they can just immediately look at the map and see where they're doing their outreach very thoroughly and what other sectors could use a little love. And here's now some information about where we are in the ACEs movement. Remarkably, almost every state in the nation has done an ACE survey through the CDC, and some have done more than one. So you can see almost every state, and Wisconsin is leading right now with doing ACE surveys every 2 years. And here is what happens when you click on this map. And this is in our Mapping the Movement map on ACEs Connection. You get information about what has happened in that particular state, plus a link to the survey. and a contact person to call if you want to provide more information, or if you want to get more information, sorry. And here you can see there's a lot of legislation that is beginning to happen across the country within states. And actually there's a hearing that's going on today in Congress in the House Oversight Committee about the need for federal legislation and support for ACEs science and trauma-informed practices. And again, here is what happens when you click on that map. You get information about that legislation, and you get a link to the legislation itself. We don't put pending bills in here. That would be actually too cumbersome now, because a lot of states are very interested in this, and we're starting to see a lot of legislation. But we only put the past legislation that's been passed enacted. And as I mentioned before, there are lots of communities on ACEs Connection, and you can go to the map and find that. And when you click on that map, on the point on the map, you can get information about where that is, and a link to their community site on ACEs Connection. Now, I want to talk a little bit about our getting to a tipping point and what's been happening in the progress on that. And that is, we've done an incredible amount of work in the ACEs movement over the last, I would say, 15 years or so, especially in the last 5 years. So as I mentioned, the elementary school and the health clinic and the Safe Babies courts at the beginning of this, there's also a juvenile diversion program in Philadelphia that has reduced arrests from 1,600 to 500 in 3 years. In San Diego, they designed a juvenile detention facility to be trauma-informed from the ground up. And there were, in the first year, I just think this is incredible, in the first year, there were no violent incidents whatsoever. Absolutely unheard of. Pediatricians who have integrated this say they have a better relationship with parents and their kids, and they can address developmental problems and identify family violence earlier. In fact, there was a pediatric clinic in Portland, Oregon, that had been asking the question about domestic violence and getting practically no positive responses until they integrated ACEs into their practice. And what happened is that built a relationship of trust between the pediatrician and the parent, because the parent was acknowledging, was talking about often their deepest, darkest secrets of what happened to them as a child, and the pediatrician was acknowledging that. And apparently just that exchange builds trust, as you might imagine. And with that trust then came a lot more people reporting domestic violence. And as a result, the clinic had to respond with a protocol that they hadn't had to do before, to make sure that they could respond either immediately or maybe just with some handouts or whatever. But they had to build all that in because there was much more reporting of it. As I mentioned, the family physician in Tennessee who treats people addicted to opioids has seen now 100% of his patients have jobs. And he also has been doing some research on this, and he says with each ACE, he and some people at the University of Tennessee, and with each ACE, additional ACE score, there's a 14% increase in the risk of continuing to have a recidivism in the in going back to being addicted to opioids. So what that means is that there has to be more attention paid to the people who have higher ACE scores, because they're at greater risk for not sticking with a program. Within 24 to 48 hours after a person recovers from an opioid overdose in Plymouth County, Massachusetts, A police officer visits and offers to take them to a rehab facility right then and there. And then he says, or she says, how about I treat you to dinner on the way? And that's a trauma-informed approach if I've ever heard one. A batterer intervention program in Bakersfield, California sees recidivism rates fall from 60% to 6%. The Wisconsin Economic Development Corporation sees the number of people quitting their jobs in that state agency decline from 20% to just 3%. Another way of saying that is staff turnover. In Cowlitz County, Washington, youth suicide and suicide attempts dropped 98% over 10 years, and that's pretty remarkable. And that's happened, that was a result of the Family Policy Council integrating ACEs science into education into communities, and communities saying, okay, we can do something with this, and starting to make some changes. So when will this be commonplace? And we want to get to this point of when change becomes unstoppable. That's the tipping point. And even though a lot of people in the ACE community think that there's we might be at that tipping point, we're not. And I'll give you some numbers that shows that. Oops, sorry, I didn't mean to go back. I won't go forward because I might go back, so I'll keep going. So a tipping point is that moment when change becomes unstoppable. And we've made a lot of progress. The science is absolutely irrefutable, and our successes are too. But we do have a long way to go, and I think not a lot of time to get there. In the United States, there are 34,000 cities and towns and counties, and a tipping point here is probably between 6,000 and 10,000 communities. Right now, we probably think there might be 1,000 communities in the US, that includes cities and towns and counties, that are becoming trauma informed. And there are 90,000 pediatricians in this country, a couple thousand of which are integrating ACEs science. So tipping point here is probably 18,000 to 30,000. If you figure a tipping point is somewhere between 20 and 30%. 1,000 to 2,000 schools are integrating trauma-informed resilience building practices based on ACEs science, and there are about 130,000 schools in the US, with about 3 million worldwide. There are dozens of Safe Babies courts now, but still, that's only 1% of family courts that are Safe Babies courts. So some things to keep in mind and this is that ACEs is a social justice issue, and parents have the right to know the most powerful determinant of their children's future health, safety, and productivity. Also, there is no them and us in this ACEs movement. It's all us. And if we keep that in mind, I think that we'll be okay. ACEs science in my book is apolitical. Toxic stress from ACEs is a human condition. No matter who you are or where you live on this planet or who you vote for, if you're put under enough stress, your body will suffer. Put babies and children under toxic stress with little or no resilience factors, and you're guaranteed to damage their brains and probably their lives. It's crucial that every child have a caring adult in their life, but that alone is not going to get us to the point of solving our most intractable problems, which is where we want to be. Only systems change will. Collaboration is very important in this, where the responsibility for driving the initiative is shared among participants, and where a local ACEs initiative identifies all the sectors within its community and uses an inclusion tool to make sure that nobody's left out. And ACEs Connection has a great tool for that, by the way, which we'll be launching pretty soon. ACEs are a universal condition. We know that ACEs and the consequences of ACEs affects everybody. It cuts across all social and economic sectors. Saying or implying that this is only a problem of poor people, especially poor people of color, is not only stigmatizing, in my book, it's ridiculous. It ignores the fact that the problem is a normal response to abnormal or toxic conditions, systemic racism, historical trauma, policies that punish instead of help, no housing, not enough food, useless education in schools where kids and their teachers are traumatized. And I want to say something about poverty here. And that is that I actually hate the way that that word is used. You know, people talk about let's lift people out of poverty as if we have to have a poverty. If there's one thing that ACEs science has taught us, it's that we don't really need poverty anymore. And here's why. Our systems were set up to manage problems, not solve them. Because we never really could believe that we could solve problems, we set up the systems the way that they're working now. And the systems are overwhelmed with need, and we don't even track what that, for the most part, track what that need is, because we can never satisfy it. But that's because we didn't have the understanding and tools to do this, and now we do. So now we can set goals, figure out how to achieve them, and then figure out what happens once we achieve them. And that's all possible, and some communities are starting to do that now. So we've accepted poverty so thoroughly that we accept that some people have to grow up in poverty, as if they, them, us again, had said, when I grow up, I want to live in rat and mold infested housing, or better yet, no housing. I want to go to schools that don't educate me and where the current system makes sure that teachers who want to teach me can't. I want to feel like crap when I apply for programs from organizations that are supposedly set up to help me, and they treat me as if where I am is all my fault and they're doing me a big favor. So we don't have to change poor people. We have to change the systems that create poor people and keep them poor. So this continuation of them, us also ignores a really important point. People in power who have high ACE scores can do incredible damage, especially if they cope with their hurting by hurting other people, especially if they're charismatic, no matter where they are. And you can find such people in business, education, the faith-based community, in politics. It doesn't matter. You saw that earlier slide that I showed about the Blue Ribbon Commission, that a gathering that I did a presentation to in Sonoma County, and how high those people's ACE scores were. And we have to keep recognizing this, is that we have to work on us first, in our organizations, in our families, in ourselves, before we can hope to help people who are suffering. And so now I'm finally catching up to this slide, but it's a good thing to keep reading because it's so critical. And this came from Quen Zora and a group of people that she was working with to create the Near at Home home visiting module on ACEs science. And it's wonderful. If you haven't seen it, just Google Near, N-E-A-R, at home, and you'll find it. Anyway, she's a public health nurse from Washington State, and she has said that science is a social justice issue, and parents have the right to know the most powerful determinant of their children's future health, safety, and productivity. And there are a couple downloads that we have at the end of this webinar that are parent handouts that you might find useful, that describe not only ACEs science, but also resilience. So humans' historical approach to changing behavior is, and whether that's criminal, unhealthy, or unwanted behavior, is to use blame, shame, and punishment. Or in the public health community, way too much information that people just ignore. So instead of using blame, shame, and punishment, how do we restructure organizations to understand, nurture, and help people heal themselves? How do we move from creating communities that manage problems to communities that manage solutions? So ACEs Connection part in this evolution is to continue to support what all of you are doing. All of you who are already involved in the ACEs movement in some way. To reach that tipping point, excuse me, of communities, we're developing an approach to support the rapid expansion of ACEs initiatives. And we're making plans to become an international nonprofit cooperative that will launch in the fall. We're adding some substantial tools and supports that many of you have asked for to help with your ACEs initiatives, especially as how they're measuring progress and outcomes, and to make it easier to obtain funding for those first couple of critical years. Now, this is a graphic that I love dearly because it describes my life, and probably many of yours. But it's not a straight line by all means. This work is often 4 steps back and 3 steps forward and 5 steps ahead and 6 steps back, and doesn't even go in a straight line. It wavers, it goes completely off track, but overall we keep moving forward, and the last 7 years of us tracking all this shows that. So we can still get a lot of inspiration from the crookedest of lines. And as one of my staff says, we're continuing to build a ship as we're sailing it. That means that most of the approaches that have worked for us in the past won't now. And integrating ACEs science in everything we do is a challenge. So that's just what it's going to be for the foreseeable future. As a person who pretty much likes change, I support this, but I also know that there's some people who don't, and usually the people who don't are people who've had a lot of adversity, and so we have to be understanding of their path, though it might be slower than ours and slower than we would like, because there is no them and us. We have to make sure that we include everybody in this shift, and that we're creating a safe place for people to make those changes. So there are some issues that I think that we have to address in the ACEs movement right now. Some people say, take this trauma-informed course, or this even one-day course, and your organization can become trauma-informed. But that's not possible. A half day is your starting point, or a 1-hour presentation is your starting point. And if you're committed to making your organization more effective and healthier, count on never going back to how you did things before, because it's not possible. You have to change to integrate this new knowledge of how people change their behavior. It's also not possible to start the conversation with how to become trauma-informed if you don't start with ACEs science, the ACE surveys, how toxic stress from ACEs affects the brain, how toxic stress affects health, how toxic stress is passed from generation to generation, and the promise of resilience research. If you don't start with that, if you don't lay this foundation and help people understand the basics, this trauma-informed stuff will become just another fad, and I'm already beginning to see that. So, and if you don't let each organization's workforce figure out how it will become trauma-informed, it's not going to work either. This is not a top-down endeavor. You can't force people to do this. You have to educate everybody and then let the organization and the different people in the organization organization, figure out how to integrate ACEs into their own part of that organization, and then develop policies. And that works. And the third point of this is, if you start with the idea that you're going to change the people you're serving or teaching or jailing first, you'll fail. You have to start with you. Organizations in the position of serving people, teaching people, jailing people have to do their own work first. I was recently, excuse me, in Oregon visiting with 6 or 7 school superintendents and their teams, and they spent 3 or 4 years at that point as a trauma-informed learning community. And this last year, they started putting their programs into place. And to a team, they said, our biggest mistake was putting programs in place to try to change kids' behavior first. We needed to change our behavior, our own behavior first. And when we did, the kids magically changed too. And that happens in a lot of places. So it's an important lesson to integrate. Sissy White, who's one of our wonderful community facilitators in ACEs Connection, said something very profound that I want to leave you with. And that is, she said this when we were talking about this one day. And she said, if you learn about becoming trauma informed and think it sounds easy, you're probably doing it wrong. It should turn your world upside down and make you question how you do everything. It should make you think about the system itself and how it operates in a whole new way. If it seems huge and totally overwhelming, you're probably on the right track. If it's mostly just new words to describe how things have mostly been done, that's not it. And if you use those words to continue doing things the way they've been done, that's not it either. The most amazing people that I've run into who are the pioneers in this, when they learned about ACEs science, they said, oh my gosh, I've been doing everything wrong. I've been doing everything wrong when it comes to disciplining my students. I've been doing everything wrong when it comes to treating my patients. I've been doing everything wrong when it comes to serving the people in my congregation. So that's what Sissy is talking about. And that's what I would like to leave you all with. I hope that your interest in ACEs science and practice continues, and whatever we can do at ACEs Connection to further that, please let me know. Thank you so much for letting me talk about this today, and I'm happy to answer questions.
Thank you so much, Jane. That was really wonderful. I really loved hearing all of the examples from around the country of communities in different areas and different disciplines that are really kind of taking on ACEs and ACEs science. That was very, very inspiring. We did get a lot of questions, so I'm going to go ahead and start there. I'm going to leave out this resources page that I know you had for folks to kind of look through, and I'll just kind of start down the questions. We received a lot of questions about specific disciplines and areas about how to integrate ACEs. And so I'm going to go ahead and run through them, but feel free to also just let us know if you have any communities or models that maybe people can look towards. And just to let our audience know, we'll be taking notes on this, and we are happy to share the answers to these questions, because I know we probably won't be able to get through all of them. Or Jane, if you want to get together and provide some specific resources for folks around their questions, we can do that after the webinar as well.
Okay, so, great.
The first one is really around a school setting, and thinking through either a community that did this really well that might be a good case study, or some recommendations for convincing a principal or a leader who may be a little resistant about trauma-informed care and the approach that they take to a child's education.
So convincing leaders is a pretty important thing, because you can't move an organization along without that buy-in. I have talked with a lot of people who say, you know, all the evidence is here. Why don't they listen to us? You know, these are our teachers or staff or nurses in a school, counselors. and the leader turns a deaf ear to all that. One of the reasons we have interest-based communities and geographic-based communities on ACES Connection is that those interest-based communities are resources for you, because you can go to that ACES in Education and you can say, is there a principal who is like my principal, rural area or in my state or nearby, so that who is integrated ACES science, who can talk to my principal. Because if a principal turns a deaf ear to the staff, then they're more likely to listen to someone who's just like them, who's integrated this. And we have way more than one principal who can do that. We have, I would say, probably now in the hundreds who can provide that information. So if the pressure from the staff won't do it, often peer pressure will. So that's one way. And the other question was just, how do you get this into a school setting? The way that seems to work best is, besides having the leader buy into this, is then that you have separate and you have a full everybody in the school is educated by about this in one setting, and then you provide further education for the different groups in the school. So if teachers and counselors and cafeteria staff and bus drivers and school nurses, so that they can kind of figure out how they're going to integrate this into their own days as they're working in daily life, work life, as they're working in the schools. And you get some really wonderful stories that come out of this and practices. And one that comes to mind is a bus driver who, when he learned about this, said, "Oh, I get it. I'm the first person that a child sees that day. And what if I'm grumpy and miserable and speak harshly to that kid? How about, what happens to that kid's day if I start that way? And what happens to that kid's day if I say, 'Hi, how are you? How's your day? Or how's your morning going? How can I help you if, there's something that the kid is obviously dealing with, and pass that information on to the teachers. So every little thing helps, and every bit of awareness helps in all parts of the school.
That's really helpful. I'm going to ask you a tough question. I know this is tough, but kind of going off of that, to create that buy-in, do you have maybe one resource, a video, a podcast, one article that you would think is short enough to kind of give people a basic understanding of ACEs for those who are not bought in, even to just start like at the ground level 101 training?
So we have a 5-minute ACEs primer that is on ACEs Connection, and it's in the, if you go to ACES Science 101 on ACEs Connection, or even on ACEs Too High, you'll find it in the video section. And that can start people out. And that was done by the people who put together Paper Tigers and Resilience. And then there's also Nadine Burke Harris's TED Talk. So I recommended those two. Also, you can peruse our video section on ACEs Connection, because it has a lot of different types of fairly short, like 4 to 6 minute ACEs primers as well. But I think the one that we have listed in ACES Science 101 is a good one to start with.
That's great. Thank you. I know a lot of people will be looking for those shortly, so we'll make sure to send link to that as well. Now, kind of changing the conversation a little bit about, once you have ACEs and you're aware and you have buy-in, one of the questions that we received was around how ACEs should be implemented. And if you have any thoughts or ideas about how others have implemented the ACEs scale. And so is it a self-report? Is it work best when it's a conversation with the individual? I think a lot of people really worry about re-traumatizing or triggering folks with the ACEs question and score. And so love to hear some of your thoughts around that.
So is this in an organizational setting that you're talking about?
I believe it is. I think the question's probably how you would use this with clients that you're working with, or students, or with people that you are interfacing or providing services to.
Okay, great. Um, there's a good example is in a story I wrote about how Wisconsin agencies integrated ACEs science. And if you just search for Wisconsin on ACEs Too High, and we'll provide the link at the end of this webinar too. There's there what they did was, and they learned from this, they educated all the state agency directors about this, and they were all bought in. And then the directors had to, or the agency heads had to figure out how to integrate it into their organizations. Some of those organizations are, have hundreds of people. So they, the mistake they made at first was to give everybody the ACE survey. And they learned that that probably wasn't the best way to do it. The best, some of the organizations did that. And they learned from that to say, well, let's just educate people about ACEs science. And then what is very powerful is if you do an anonymous survey, like by an instant poll that you can do on your phone, that can show the entire group's ACE and resilience scores. And when you do that, it's a shared experience, and people can they have background. First, they have learned about ACEs science and resilient science, and then they are ready to learn a bit more, and then to do this group ACE survey, they don't feel so alone. And the other thing is when they start the education, they say this may trigger some people, and that's okay because that's part of growing. But if you're having problems, we have a counselor here or someone from Human Resources who has experience in counseling to help you and to talk with you about that. So there's all these ways of trying to make people feel safe as they are exploring this information. And the thing is that because this is very personal, a lot of people will immediately go to what happened in their own lives, and so they'll hear part of the presentation, but they won't hear it all because they've tuned out to examining what happened when they were children. And so this is why you have to keep repeating the information about ACEs science with every presentation that you make, because people will learn a little bit more about themselves, about the science, about their organization. They'll, their area of understanding will increase with each time. And one quick example of that, as I've probably heard Dr. Folletti describe the ACEs science and do his presentation, I don't know, more than a dozen times, and he does the same thing every time, and yet I hear something new every time. So that, I think, happens as people start learning about this and experiencing. But the main points are, don't drop the bomb on people right away. Let them learn about this, talk about it, then do the ACE survey anonymously, and then talk about it some more, and know that this is part of a long-term commitment on the part of the organization, that you're not just going to present this information and then walk away.
I love that. Thank you. We have been having a lot of conversations about triggering folks and what that looks like when you're using an assessment, in particular through our poly victimization initiative and family justice centers. And we found that actually most of the clients that we have established rapport and trust with have very positive experiences kind of connecting what has happened in their past with their physical body. But again, like you said, it was a very intentional conversation of educating, providing resources and support, establishing trust, really ensuring that it was the right time and that they understood the process and what could happen. And then again, using that information, not just here's your score at the end, but what does this mean? How can we support you further through this process? So I really appreciate that comment. And I think it, as you mentioned, understanding and education is power. And when people understand what happened and how that could have impacted their lives, it really gives them valuable tools to make changes. So thank you.
Yeah, absolutely. It gives them tools, and it opens a door to, the four things I talked about, that they weren't born bad, the things that happened to them were a kid weren't their fault, that they, the way they coped was completely appropriate, and that they can change. And that is so self-empowering, and it's changed, tens of thousands of people's lives, probably more than that by now.
Yes, that's wonderful. Thank you. And so going back to some specific scenarios of where ACEs is being used, we have three questions that are kind of similar. So I'll go ahead and ask about these three scenarios and see if you have any thoughts. People would like to know how others have been incorporating ACEs into teen court programs for youth from 10 to 17, or the juvenile justice and delinquency systems, and then the emergency rooms.
And what was the last one?
Emergency rooms.
Emergency rooms, okay. So San Diego Youth Services is an example of an organization that participated in the National Council on Behavioral Health Trauma-Informed Learning Community. And they started with themselves, and then branched out to the people they serve. And as a result, they designed a youth facility that was a drop-in place, as well as a rehab and a place where kids could live for a while. The way that the kids wanted to, after they were educated about ACEs science, the way that kids wanted that facility to operate. And I think they got rid of something like 300 rules and only had, maybe a handful left because they realized that they didn't need all those rules. If people understood what the purpose of this facility was, and how the people would be treated, and how the people the adults were in charge of it. So I think that the secret to working in facilities that serve kids is to give kids a voice in that, no matter where they are. And I think that that's common for every organization, no matter what age group you're working with. For juvenile facilities, as I mentioned, the one in San Diego, that county that became trauma informed was designed to be trauma informed from the get-go. If you give kids a voice, if you tell them that if you give them space to, when they're triggered, to act out safely if they need to, and to help them and show them how to do it differently next time. When you understand the incredible trauma that these kids have gone through, it's not surprising that they're not going to get it on the first time, that it's going to take time. That's critical, that continued understanding and support, so that kids will feel safe, so that they can start their healing. And it won't happen until they feel safe. And that goes for homeless people as well. I know I was talking with, did a presentation for some law students, and they said, one of the students said, well, I'm working as a volunteer in this homeless shelter, and why won't they open up to me right away? And I said, Well, it's going to take a long time because they have had, especially people who are homeless, no matter what age they are, um, they've had so much trauma that they don't trust anybody. And so you're going to have to show them that over and over and over again that you can be trusted before they'll take that first step. So it's not just they won't believe you, and that's just the way it works. In ERs, there's a guy named Dave McCullum, Dr. Dave McCullum, who was one of the pioneers in this arena, and he is now retired. But what he did, especially when there were people who came into the ER and he couldn't figure out what was wrong with them. He did all the tests and they were still in pain or whatever. And so he would just say, "Can I tell you about this knowledge we have about that applies to many people who have things that we can't figure out?" And over and over and over again, he would get people who were brought to the ER on a stretcher and they would walk out, and he would give them resources that they needed. He would just be a willing ear to the things that had happened to them currently as well as in their childhood. And he would be the one who would bring up what had happened in their childhood. And it's that creating the space to listen and acknowledge that makes a lot of difference in where you wouldn't think it would, just because the way our systems are set up now.
I love that. Thank you. It's a good reminder that we don't always have to do something to help people heal, but that a lot of times it's creating that space for conversation and for support, and just that human connection aspect is so critical. So I really appreciate that.
And what they're finding is that is doing something. In fact, I ran into or talked with a couple of internists at in a hospital, and they started integrating ACEs science into their practice just about 3 months ago, and they're over the moon about the difference it's made in their patients' lives already. And it's just the listening and acknowledging that turned the corner for them.
That's wonderful. And then just more specifically, going back to the juvenile justice delinquency systems that we have, do you have any great resources or people who are doing training specifically for judges, DAs, probation, police, or defense attorneys around ACEs?
Yes, there's actually quite a bit going on in different communities. For judges, I'll send you some resources. There are, I think now 20 courts and 20 judges, and maybe more now, in Florida that have started safe babies courts, or early childhood courts, I should say. And I know that there's been a lot of movement in drug courts and youth courts with this, and I'll send you some of the resources for that that we've put together on ACEs Connection.
That will be great. We'll make sure that everybody gets a copy of this kind of question interview conversation that we're having. So thank you, Jane. Excuse me. And just before we move to other longer questions, others wanted to know, are there any Canadian centers using ACEs or communities that are using ACEs in Canada?
There are, and they should be on the map. But there's some in Eastern Canada and also some in Western Canada, and I think there's one now in Central Canada too. So yes, there are.
Wonderful. And we'll again send all of these resources to everyone who's attending this, and make sure we include links so that everyone's getting everything around this.
And also, I just want to mention one more thing in Canada. The Alberta Family Wellness Initiative has done remarkable work in Alberta, Canada, and they have a great module for learning about brain science in relation to toxic stress that's on their site, and they've done a tremendous amount of work in their own community, as well as informing people about brain science around the world.
Wonderful. So we have a tough question here. And so we know that in order to really have an impact and use this ACEs science, a core component of that is trauma-informed approaches and practices, like you said. And as you kind of mentioned or alluded to, we've seen that trauma-informed approaches has become a little bit of a buzzword, and a lot of people are saying that they do that without really having changed their practices or their approaches or their philosophy. But do you have any recommendations on how to engage organizations around evaluating if their practices are truly trauma-informed, or how to guide that conversation? Any resources that you have through ACEs Connect?
Yes, we do. We have a bunch of different types of evaluation approaches, and that's one, and it's in our resources section under evaluations, and also Oregon ACEs. Their state collaborative has a lot of information as well. The other thing that we will be rolling out, I mentioned earlier about new tools, is that we have a community resilience tracker, and one part of that is the milestones tracker. And what we did is we looked at all the organizations across sectors who had started making changes in their organizations to become trauma informed. And we identified 11 different milestones that organizations need to pass to integrate into their organizations to become truly trauma informed. Now, every organization becomes trauma informed differently, because what works for a school won't work for law enforcement, won't work for a church. It's all different, but these milestones are the same for all of those. So as far as communities go, we will have that tool up and running so that communities can start measuring what they're doing. And so those are two resources. And the third point I would make is that this is for the organizations that say schools, there's a 3-year transition to the point, at least a 3-year transition for schools to say that they are trauma informed. And any school you talk with that has made that 3-year transition will tell you they're just beginning, because once you make that switch into integrating all this knowledge and these practices, it widens your scope of, wow, we really need to do more here or more there, and look at this opportunity here. We could be doing this instead of this. It's just amazing. But I will say that it's at least 3 years for most organizations, and probably longer given the size of the organization. I know that when Wisconsin started this, it was a 2-year program, but they decided to increase it to, they realized after the first year that it had to be a lot longer if they were going to make the progress they wanted to make. And so it was continuing. They really didn't have an endpoint for it.
That's helpful. And that 3-year marker sounds long, but in terms of changing practices and structures and processes is probably very short, especially in a large kind of system as a school. So that's
right.
kind of a helpful marker point.
Right. And you can't expect to like train everybody on trauma informed practices and expect like a large organization, like an organization that has 1,000, 2,000, more people, or even several hundred. It has to go through that process. You educate everybody about the foundation of ACEs science, and then about trauma-informed practices, and then you have to go back down into your, the molecular part of your organization. Say, okay, how does our department change? what do we do here that's going to be different? And then you can develop the policies for the rest of the organization. But you can't really do it until you get that feedback from the people who are actually doing the work.
Absolutely. And then what we found is once you've really trained everyone, people start leaving and you get a new cohort. So there's got to be ongoing training
Yep.
for a very long time before it does become institutionalized.
Yep.
Definitely. And so I know we only have about 5 minutes left, so I think we can maybe squeeze in 2 questions before we wrap up here. But one question came in specifically about any resources or tools or communities that are utilizing ACEs really well, specifically with the elderly community, and what that looks like for that group.
Yes, so there is I can think off the top of my head, there's an organization in Albany, New York, that has done this with older patients. And the thing is about being people who are in their geriatric years, they have ACEs, if they're having problems, especially if they're addicted to anything. So the same approach works for them as anybody else. It's that education, it's the tolerance for not adhering to what you should be doing. People are people pretty much everywhere, and if geriatric patients haven't had their ACEs addressed, and if they have a lot of ACEs and few resilience factors, they're likely to have more issues, not only physical issues, but also emotional and other social problems and all of that. I think that the best thing that any organization can do to start this is say, hey, look at this new knowledge and what do you think about it and how do you think it affects your life, and then see how things go from there. I think it's really interesting, this particular organization, when they started integrating ACEs, didn't want to tell people about ACEs. They just wanted to, get their score as a part of a survey. And I actually think that that's definitely not the way to go. I know a lot of people say, well, what if they get, they get sad or they start crying? And it says, well, if you're a counselor, who better to be with when you're doing that? And other people say, well, what about, if they get triggered? Well, as someone who has an ACE score of 7, I can tell you that anything can trigger you, a smell, a sound, whatever, and you learn to deal with that, and what better place to be triggered than a safe place, so that you can have someone to help you understand where the triggers come from and how to deal with them better.
Definitely. That's very helpful. And again, we'll be sharing all of this information with folks who are asking these questions. I think the last question I have, and we'll wrap it up from there. I noticed one of the statistics you had in the graphic up front was around 43% of the people with ACEs having levels of hopelessness. And we at Alliance for Hope International obviously intentionally had hope in our name because we've done a lot of work around hope theory and have been working very closely with the University of Oklahoma, the Hope Research Center, and Dr. Chan Hellman on that, and really looking to measure hope. And so I'm just wondering, are there any new inroads that the ACEs movement has made into looking at measuring or how to increase hope? I know resiliency was one of those pieces, but what does it look like for hope theory? Do you know?
I can only guess what I would think it would look like for hope theory based on the hundreds of interactions, thousands of interactions I've had over the last several years in looking at this, actually since 2004, is that those 4 parts, that I wasn't born bad, what happened to me as a child I had no control over, that the way I coped was absolutely appropriate, and that I can change, that so much opens the door to hope. And, I saw that in Walla Walla, Washington at Lincoln High School when they educated all the students about ACEs. They said, oh, well, I can change from this. I can grow from this, instead of thinking I'm a bad kid and I'll never be any different. So I would actually love to see some research about that. And uh, and I think probably a way to do it is, perhaps in a school where ACEs aren't used, versus a school where all the kids are educated about ACEs, and see what the difference is.
Definitely. And I would encourage folks to dive into our HOPE research, where we've really been measuring ACEs and HOPE at the work that we do here at Alliance for Hope International is Camp Hope America. And for the last few years, we have been documenting children's ACEs score, really providing them that community of support, that validation, and then measuring HOPE pre and post Camp Hope in our activities. And we've really seen a statistically significant increase, which has been very meaningful. And so I'd love to, see ACEs and the ACEs community really start using the language around hope theory as well. But with that, Jane, thank you so much for your expertise, for your time, for sharing all of these nuggets of wisdom, all of this resources. We've been getting comments throughout the entire webinar about how thankful people are for this educational space and for this opportunity to chat with you. As we close up, just want to remind folks a couple of things. We will be having our conference May 19 to 21st in San Diego, so please save the date. We'll be having conversations around ACEs and polyvictimization, trauma-informed care, and so much more. So we hope to see many of you there. And again, if you are looking to start a family justice center and really want to dig in deep around how systems can collaborate and integrate frameworks like ACEs and polyvictimization, we encourage you to register for our annual Leadership Summit, September 24 to 26 in Oklahoma City. And then please join us for our next webinar. We do have a webinar on August 20th with Dr. Oliver Williams, who will have a panel, and we'll be talking about the intersection of faith and domestic violence. So for those of you who can join us, we look forward to talking to you then. And again, Jane, thank you so much. And thank you everyone for joining us. We hope you have a great day and a great weekend.